So we're going to go ahead and start the webinar. But before we do, I'd like us to just have a quick round of introductions so we know everyone who's on the call today. I guess I can start. I'm Andy Kendall. I'm the Tech RRT Program Manager.
I'm Scott Loeb, the Assessment Advisor, ACF.
I am Daniel Hadou, the Social Behavior Change from International Medical Corps.
Hi, this is Angeline Grant, Action Against Hunger.
Hi, this is Dr. Amin, Nutrition Cluster Coordinator, International Medical Corps.
This is Susan Brickman, Senior Advisor for Nutrition and Emergencies, International Medical Corps.
This is Dr. Mazin Hussain. Sorry.
Hi, Christine from Save the Children, IYCF Global Advisor.
Who is next?
This is Najwa. Sorry. This is Najwa Iskallah from UNICEF Iraq.
This is Dr. Mazin Hussain, Chief of Health and Nutrition, UNICEF Iraq.
Jonathan Hemrell, OFDA, DC.
Is that everyone? Sorry, I can't see the list, so who's there? Is anyone missing? Okay, if not, then I'll go ahead and start. As we all know, we're here today to talk about the recent TechRRT deployments to Erbil, Iraq. I'm happy to see a couple of colleagues on from Iraq, and welcome everyone. Okay, oh, wait, let's see if my screen is going to change. A second, it was where, there we go. Okay, so first, just to go through what we're going to discuss on today's webinar. First, we're going to discuss the introduction and the objectives of the webinar itself. I'm going to give a brief overview on the Tech RRT. Then a little bit of background on the deployments to Iraq. Then there'll be a presentation from each of the advisors' work. The first one's on the assessment advisors' work. Then that'll be followed by the IYCF advisors' work, and then the social behavior change advisors' work. Finally, we'll have a short one slide on the overall lessons learned from the deployments, and then open it up for discussion. First, the objectives of today's webinar. Really, we started Tech RRT deployments basically from the beginning of 2016, and back in January, so after a year of deployments, when we were meeting, trying to work out better ways of doing things, we realized it would be really nice to have better information sharing and to be able to foster discussions on the situation in countries. So we've decided that it would be worthwhile to try to have post-deployment webinars from the deployments that take place to allow people to hear what work they've done, foster discussion on the situation in general in the country, and also as a means to help to improve follow-up of the work that has been done during the deployments. I am the facilitator. As I said, my name is Andy Kendall. I'm the program manager for the Tech RRT. Then we've got three presenters. Well, we should have three presenters. The first one is Scott Logue. He's the assessment advisor. The IYCF advisor, who actually was on loan from Save the Children humanitarian surge team, Sebsibi Teshome. He's currently deployed to northern Nigeria, so unfortunately he won't be able to be with us today to present. But so Daniel Take will be able to do the presentation for him. And then we have Daniel Take, who's the SBC and CMAM advisor for the Tech RRT. Briefly, what is the Tech RRT? It's a technical rapid response mechanism to support collective work for nutrition in emergencies. It's a consortium, and the consortium is led by International Medical Corps in partnership with Action Against Hunger and Save the Children. Our funding comes from OFDA, from USAID. and it's in close collaboration with the GNC and UNICEF. The main objectives of the project are to improve the overall emergency nutrition response by deploying technical advisors and by providing remote technical support. We also do, during non-deployment time, our advisors work on global initiatives to be able to support their advancement. Okay, now to go into a little bit of the detail about Iraq, I am everybody's familiar with the situation, I think. We've had a lot of things going on in Iraq since basically 2003. But in 2014, in August, it was actually declared a level 3 emergency in the country. 15 million people are currently living in conflict-affected areas. Many areas are under control of armed groups, and therefore there's limited access to health services. Since June of 2014, there's been continuous displacement, and that's increased even further with the Mosul operations. So at the deployments, they started in the beginning of December, end of November, beginning of December, and just over the time of the deployments themselves, which were 8 weeks and 10 weeks long, they saw a huge increase in the number of people living in the IDP camps. So in the beginning of December, there was roughly 70,000 people living in the new IDP camps, and that increased to over 140,000 towards the end of the deployments. So as you can see, the situation was rapidly changing. Nutrition is actually a working group within the health cluster. It's not actually a cluster on its own. And health and nutrition activities in Iraq are mainly implemented by the Ministry of Health and their directorates of health, which are at the governorate level. So UNICEF, particularly in nutrition, is supporting the Ministry of Health, especially. NGOs are obviously present in the country, and they're much more active in the health sector than they are in nutrition sector. So UNICEF actually started the request process for the Tech RRT advisors back in November, because they saw that there was an urgent need for additional human resources to be able to effectively respond to the Mosul crisis. They wanted to hire a nutrition specialist, who I understand today is now on board. We're happy for that. But in the meantime, they wanted to be able to start the emergency response as soon as possible, and therefore request our assistance. Okay, I'm going to hand over the presentation now to Scott Logue, the assessment advisor. But first, just to get our mindset in the right region, here's the map of the region. Erbil is in the Kurdistan region in northern Iraq. Okay, over to you, Scott.
Okay, great. Thank you very much, Andy. Can you hear me, Andy?
Yes, I can hear you perfectly.
Okay, great. Can you bring up the next? Okay. So here we're zooming in. So this is you'll notice on the bottom part of the screen you'll see Erbil. If you could bring in all the other assessments. So in the green we have the SMART assessments, and in the red is the barrier analysis. So we were based in Erbil, and then we would travel back and forth each day to the camps where the assessments took place. So to the north, it would be at most 3 hours for the Hook, and then to the south, it would be around 2.5 hours to Guyera. Okay, next slide. So I'm going to talk a little bit about the nutrition and health assessment which took place. Next slide. Is it going? There we go. Okay, so the objectives in the assessment personnel. So the deployment took place roughly 10 weeks, November 22nd to February 3rd. So basically, due to the ISIS-controlled Mosul over 2 years, there's a lack of nutrition and health information available for the relief efforts and planning. So that was the overall reason for conducting these assessments. So you have the main objective was to provide updated information pertaining to nutrition and health, and then there were several specific objectives which we listed here. in the questionnaires. So the assessment personnel, the management, the coordination committee, it actually consisted of the Nutrition Research Institute, so it's NRI, which is a branch of the MOH, UNICEF, and Tech RRT, which was myself. There was 4 supervisors, 2 were from NRI and 2 were from UNICEF. The survey teams, we had 8 teams of 3, so 24. We originally had 9 teams, but we lost a few people at the end of the training, but we were still successful. And the data entry staff, we had three wonderful staff from NRI that did the data entry during data collection itself as well as afterwards. Next slide. So the anthropometry results. Well, at first, the cluster, it was the cluster sampling. It was a 2-stage cross-sectional cluster sampling using the SMART methodology. So we had 38 clusters planned, and then the final we included 38. We planned for 413 children, and it included 567, which is 137%. There was 608 households planned, and we included 588, which was 96.7%. So the GAM and MUAC are considered low for WHO classifications of less than 5%. And similar to a survey and an assessment that took place in Kirkuk in March 2016, where they found 2.2% GAM. There was 1 case of edema identified. The child was 3 months. And the stunting is considered medium based on WHO classification of 20 to 29%, and similar to previous national assessments. The underweight was low based on the WHO classification of under 10%. Next slide. So now I'd like to talk just a little bit about the actions that contributed to the high quality results. So regarding the training, I should mention that these actions can be applied to any assessment conducted by the audience today. So the training itself, the 7-day training, it was a robust training that included the mandatory tests by SMART, so that would be the standardization test, as well as the field test, and time to practice the questionnaire. So I can't emphasize enough the need for lengthy training to increase the likelihood of achieving high quality results. The supervisors, we actually had a pre-training for the supervisors before the enumerator training, where we reviewed the slides and we divided up the training sessions. And I believe 3 of the 4 supervisors had previous SMART training as well, which was great. The measurements, so the staff had the opportunity to practice measurements 2 times before the standardization test. And the training of the questionnaire itself was a full day, and we also fit time in for role play practice before the field test. We had lots of time to practice. The supervision, each day 1 supervisor would rotate between 2 teams, and each team had 1 female. Supervisors would check questionnaires daily, and they provide feedback to their teams the following morning. So basically, they'd get back, they'd collect the questionnaires, review them. The next morning, they would provide feedback before they went out for data collection the following day, and make any necessary changes before the data was entered. So the survey manager, which was me, conducted the plausibility checks starting on day 2 and provided daily feedback to the teams when they came back from the field as a whole, and if needed, I also conducted meetings with individual teams. So we had the opportunity to recheck most of the flagged data, and the reason for this, I mean, this is not always possible, but the reason we did this is just because we had the opportunity, because sometimes we would return to the same camps to do different clusters. We had the opportunity on the last couple of days of data collection. So for the data entry, the anthropometry data was entered daily, as well as the household questionnaire. Now we emphasized more during the actual data collection on the anthro. So the anthro was checked daily, and at the end of the data collection, all of the questionnaires data entry took place. Yeah, so double data entry took place. Next slide, please. So now here's some lessons learned, which we can bring forward to follow-up surveys in Iraq, and once again, this stuff can be used for assessments in general. So it was recommended, we conducted a standardization test. There was 18 people that were being tested, and to be honest, it was just too many. It was too many because it was taking too long. It was becoming stressful for the children. So in the future, I would recommend if you're going to have more than 10 people tested, have 2 days of split the standardization test. So have 2 days, or bring in 10 additional children. Have one day gap between field tests and the last day of training, and this can be it could be a half day. It's very important to provide feedback. You have to get information from the field test. Pretend it's like day one where you're actually you're analyzing the data, practicing your data entry, and most importantly, you're providing feedback to the team. If you do this, the change in quality of the interviewers will go up a lot if you do this. The training staff train additional staff in case of dropouts. So we actually lost 3 people. So it's always important to train a few extra people, and then you can include them. They can rotate between teams and whatnot if they don't drop out. So for the data collection itself, the context of Iraq, I won't go into too much detail here, but before the assessment itself, we had overall population data, but then we needed very specific for each camp to get the information to do our cluster selection within the camps. So we did this before the camps, or before the assessment itself, and then during the assessment, it became more difficult to get a hold of people during the actual data collection. So I would recommend to just keep in constant contact with the camp managers during data collection. And for the data entry, we implemented EpiInfo 7 template. So basically to replicate the questionnaires so that they can enter the data. And based on feedback from the data entry people, these were very useful for longer questionnaires, but if it's a shorter questionnaire, for example, just anthropometry data, it's better to just enter the data, which they were doing before in Excel, because it's faster. Thank you very much. Andy?
Thank you very much,
sorry,
Scott.
Daniel. Thank you.
Yeah, I'm going to take you to the IYCF presentations on behalf of my colleague Sabsibe, who is currently deployed to northern Nigeria, Borno State. So I'm going to take you to the overall purpose of the deployment for IYCF for nutrition and partners involved with it. And the purpose of the deployment was to provide technical support on IYCF for nutrition partners in the humanitarian response due to this Mosul crisis. I would like to give you an IYCF context for Iraq, why it was practice is low, the indicators is very low, mainly due to culture of mixed feeding, distribution of free infant formula to all infants as part of Iraq's public distribution system, regardless of status, and outdated guidelines or policy like IYCF strategy since 2005, and also lack of enforcement of laws and regulation in regards to international codes of BMS. I'm going to give you a few charts on why IYCF matters in emergency as well as in developmental aspects, not only for Iraq but globally, especially for Iraq. I want to emphasize that based on the UNICEF, WHO, World Bank level and trends of child mortality report 2014, the neonatal mortality in Iraq was around 55%, which is very high. Interestingly, also the rate of progress towards Millennium Development Goal 4, the neonatal mortality rate is remain static for the past 20 years, since 1990 to 2010, while the other mortality, under 5 mortality trend was on decreasing show. Though there are importance of IYCF on child survival by applying two behaviors like exclusive breastfeeding and complementary feeding, which has a single largest impact on child mortality of all preventive interventions. The same thing, the early initiation of breastfeeding is a potential for reduction of neonatal mortality rate, which if can be applied, these behaviors, mainly in Iraq, it can be decreased this high mortality, neonatal mortality rates. During the deployments, there have some quite achievement been achieved, and these are like advocacy on IYCFE to different clusters, lead clusters, WASH clusters, protection, food security, health. Also, there is a development of IYCFE action plan after 1 day IYCFE orientation to all stakeholders and Minister of Health and Directorate of Health of the country, and development of breast milk substitute guidelines for nutrition working group and the Minister of Health and DOH Directorate of Health. It have been technically revised, touch the strategy of 2015. So there is a IYCF strategy in 2010, 2021 for the latest national nutrition strategy, but this is mainly being touched on the technical aspect. It is also being conducted the capacity building training for 18 participants from 11 governorate out of 18 governorate, and we have 13 participants from Minister of Health or Directorate of Health, and 1 from UNICEF, and 1 from WFP, and 3 from NGOs. Challenges are limited adaptation and implementation of the 2005 national strategy for IYCF, lack of recent data on IYCF and IYCFE especially, few partners implementing nutrition or IYCFE, lack of enforcement of breast milk substitute code, prevalence of IYCF practice low, contrary to high level of skilled birth rate. According to MIX 2011, the skilled birth rate in Iraq is more than 90%, while the prevalence of the practice of IYCF is very, very low. Distribution of free infant formula to all infants as public distribution system. So we have also forwarded some recommendation like strengthening the nutrition sectors or nutrition working group and their activities. Advocate for resources for nutrition activities, because the current resources mainly focus to health sectors and other sectors, which undermine the nutrition activities which is going on in Iraq. Advocate for more partners to work on IYCF and IYCFE. Advocate for removal of infant formula from public distribution system, or replace, substitute with infant with IYCF best practices, good behaviors, enforcement of BMS laws and regulation, establish BMS programs for infants and children with no option to breastfeed. Capacity building of health workers is also one of the main recommendations on IYCF, as I have previously mentioned that the skilled birth attendant is around more than 90%, but the practice is very low. Following this second data review of IYCF-E, the consultative discussion, orientation, training, we have come up on to do barrier analysis, and I will take you on the barrier analysis finding, especially to IYCF social behavior change activities. I'm going to give the introduction and the objective and why barrier analysis was done. Barrier analysis methodology is a useful tool for more evidence-based and informed effective behavior change, which was developed by Food for Hungry International in 1919, but subsequently updated by core groups. The overall aims of this barrier analysis were to gain needed information, especially on 4 important IYCF behaviors to inform behavior changing programming in KRI. At the same time, building the capacity of monitoring and responding with barrier analysis methodology. Social behavior change approach in KRI, IDP campus, there are different approach through posters, billboards, brochures, as well as SMS plus Facebook, health education at primary health care, community outreach workers, and radio spots. However, this approach was not systematically standardized and well monitored and updated based on the context. I'm going to take you to the finding, as previously Scott mentioned that on the background of where the assessment was done. We have done 4 behavior assessment in 8 IDP campus, 4 in two governorate, the Hook and the Erbil, 4 in each. I'm going to highlight here the key determinants between doers and non-doers response differences. For behavior 1 on early initiation of breastfeeding, we found that 4 determinants, but the common key determinants for both governors is on perceived self-efficacy, what makes them difficult. And this is, we found that the cesarean section delivery, there are high cesarean section delivery in Iraq. So most of non-door mothers are 5 times more likely not to initiate early breastfeeding for the children, and also stress. So this is the key common determinants found in both governorate. The second behavior was exclusive breastfeeding. We found 6 determinants, but out of 6 determinants, I'm going to highlight 2 key perceived key determinants. One is perceived self-efficacy, what makes them difficult not to exclusive breastfeeding, and the social norms, the social norm, who approves or disapproves. So non-door mothers are 2 times more likely not to exclusive breastfeeding. They perceive that the breast milk is only not satisfying the child. And they do also have a doubt that they perceive that breast milk is not enough until 6 months. So that is why there is high practice of mixed feeding in the country. Interestingly, there is the social numbers, though mothers say that 2 times more that they have support from their family members, mother, father, sister, brothers, which is very interesting, which I haven't seen in other countries and contexts. The third behavior was about complementary feeding, mainly on meal frequency for children 6 to 23 months, on feeding 3 or more cooked meals per day. We found 6 determinants, but the key determinants, common key determinants for the 2 governments was the negative consequence of not feeding 3 or more cooked meals for the children, because they perceive that they have more diarrhea, vomiting, and allergic reactions. So they are not practicing these behaviors. And the fourth one is the dietary diversity for children 9 to 23 months, feeding 4 food groups out of the 7 food groups. We found 5 determinants, but we found one common key determinants in both governors, that is access. How difficult it is to get food from at least 4 food groups. They say that most of the non-door mothers 2 times more likely to say that very difficult. This is of 2 reasons. One is because of the security issues. People, they are not often allowed to go out of the camp to access the markets, which is the market is out of the camp. And second is lack of resources like money or income generating activities to earn money and buy these different food groups. There are also some challenges, and these challenges was the lack of knowledge about barrier analysis as a tool and social behavior change as a programmatic approach. Also, lack of clear messages and information on potential harm on optimal exclusive breastfeeding and optimal complementary feeding, as well as cesarean section delivery. Lack of skills on development of contextualized and well-informed ICC materials. Lack of monitoring and evaluation of existing social behavior change tools and activities based on the social context and cultural and norms. So we have put some recommendation, and few of those recommendation is orient the development of all ICBC materials to include field testing and in consultation with the community. Highlight social behavior change activity as priority in emergency, not only for development programs. So to advocate resources allocation with the health clusters. Advocate for integration of nutrition or IYCF and social behavior changes with intercluster forum to bring nutrition and IYCF as a priority agenda, because the other clusters, they undermine things that are low GAM and some in the country. So the nutrition was undermined by other clusters. Establish nutrition technical working group to review policies, guidelines, and strategies related to social behavior change for IYCF, and continue support of developmental organizations or partners to invest in the capacity building of the health staff on nutrition generally and specifically on social behavior change for IYCF activities in health service delivery at the community levels. Hello?
Okay, sorry
Yeah, we're
guys,
here,
I was just on mute. Yeah, okay.
You just have to put the screen on full again.
Yeah,
You're back.
I've got
You
it.
just put the full
It's
screen.
coming. There we go. Okay. Thank you, Daniel. That was very interesting. I'm looking forward to the discussion after. Now, I just really wanted to go into a few points on some overall lessons learned from the deployments. I'm sure there are a lot more that we could talk about, but some of the pros and cons of joint deployments. In fact, the three Tech RRT advisors went out more or less at the same time. As well, there was a nutrition cluster coordinator, Lovely, who's on the call today, who also deployed at the same time from the GNC. So there were four people that were new and additional support at the same time. Obviously, there's some definite benefits from everyone being out there at the same time, in that it's a great way to enrich the work. You've got a lot of ideas that are able to be bounced back and forth between the different advisors. But at the same time, we have to remember that in a country office, particularly not the capital, there are a limited number of staff and resources, not just within the host agency, but amongst the agencies in general and within the government, particularly for at the same time that a smart survey goes on. I think we all know that smart surveys take a lot of attention and time of everyone, as they should, to be done well. But it also means that resources are split between the different advisors. Not just human resources, but also things like cars and security departments and things like that. Then there's also the potential that the assessments actually could have informed the other deployments. So as opposed to necessarily doing them all at the same time, that one could have learned from the other and built upon each other, which wasn't possible with them all being done at the same time. But we shouldn't underestimate the level of enrichment of the work between the advisors. We also need to ensure that there's involvement and buy-in from the collective stakeholders, as well as key stakeholders of all the activities that the Tech RRT advisors are working on. It just means that that everyone is going to support it in any way they can. And finally, that in general, we've noticed this not just from this deployment, but from other deployments as well, that when the Tech RRT advisors are involved in things like national strategy and guideline developments, we have to really be clear on expectations, because these processes are usually quite long process. And so we need to really think through what exactly is the role of the Tech RRT advisor in that activity during the time of their deployment, whether it's 6 weeks or slightly shorter or slightly longer, to really pick out what is the activity that they are going to work on and be able to move forward, and what remains under the actors who are on the ground and will carry it forward after. These are a few things that were highlighted. I'm sure there are many more things that we can discuss, but that's some of the things we want to highlight so far. Otherwise, we just really wanted to open up the floor for discussion and talk about any questions you have. Before we really get started, I wanted to, Moasem was the in-country supervisor for the 3 Tech RRT advisors, so I wanted to actually allow him a chance to give some input now before we go on to questions.
Shall I go ahead?
Yes, please.
Thank you very much. Thank you, Andy. I think a huge thanks to you in particular, since the start of the deployment until today. I think non-stop, tirelessly and uninterrupted, you have been in touch, in coordination, and provided all possible and necessary support. So I wanted to really start with a huge thanks to you to start with. And then to all 3 advisors who came in a very difficult time, including lovely Amin, who is also here but came with another source. But all 4 of them were very critical and crucial at that time when UNICEF really didn't have anybody on the ground. There was a huge demand. There was a lot of expectation. And as lead agencies, we needed this support badly. And we got very much on time and without much delay or without any much bureaucratic process. So I would like to start with a huge thanks to the the advisors, to you, and to USAID for making Tech RRT so user-friendly and so flexible to respond and to be so responsive, to be very honest. So with that, on behalf of UNICEF, I will try to summarize. I think most of our colleagues could not be connected because they just finished one workshop 2-3 minutes before this call starts, and they are now on their way. Either somebody is on their journey or some people couldn't arrive from the field. So I'll be reflecting what I collectively heard from people on different times. First, I think it's good to start with a positive note. The best of all these things of this.
I can't hear you, Dr. Moazam.
Dr. Moazam, are you still there? Oh. Okay, I'm not sure if there's internet connection problems on his end, but perhaps while he's not there until we can get him back, maybe we can just open the floor for discussion and questions now. If anybody wants to ask questions via the chat, you're welcome to do so, or just hop in. Can everyone hear me? Can anyone hear me? Yes, okay, good.
Yes.
Okay. Don't be shy, we're a small group.
I think this was. Hello.
Hello.
Why
Hello, I
they are
think
recording?
we've just we've lost you for quite a long time.
Oh, is it? Because I just
Yes.
heard about that the recording is on, and I don't know why they're recording. So when
Yeah.
up to what did you hear, so that I know where to repeat?
Okay, we lost you just as you were about to say you collected comments and you wanted to start with the positive, and then it cut out.
Oh gosh, you didn't hear the beautiful thing. Okay. Do you hear me now?
Yes, well, loud and clear.
Okay. So what I was telling is that the most beautiful part of this whole deployment was the speed of the response, the user-friendly mechanism, the non-bureaucratic approach, and the flexibility and the readiness. Means the time that we agreed to get somebody from TechRRT, it was only one page fill up, signed by the rep, sent it to TechRRT, and within 2 weeks people started arriving, and within a month I got all 3 advisors on board on the ground. So what I was telling that in my 15 years, I have worked more than 5 major emergencies around the world. I don't think other than UNICEF's own IRT, from standby.
I think we've lost him again. Anybody else hear him?
Yes, but we lost him again, I think.
Yes, okay, all right.
Yeah.
Okay, does anybody have any questions or want to talk about anything? Because I'm not sure we're going to get everything from Dr. Moazam.
I think I like to hear some negative things from Dr. Moazam. So it will be helpful.
I had a question for Scott while we're waiting. So, Scott, you were talking about the changing population, I think, and the recommendation of keeping in close contact with the camp managers. What would you, for not specifically for Iraq, but in general, when you've got a situation where the population is changing very quickly, if you're in touch with the camp managers, if you do the sampling several days ahead of time or up to a week ahead of time, and it's changing on a daily basis, at what stage, I guess, when the population increases or decreases, by what percentage would you consider doing a resampling?
Good question. So basically, this can be applied to all assessments, but basically, so for our cluster selection, so the stage 1, we broke up into 2 stages where we before the assessment took place, the data collection, we had the populations and we broke it down by PBS. But then it was the issue, so we selected our clusters. But what you're talking about now is when you have your clusters, even like within the camps or even in the villages or whatnot, if the population is changing rapidly. And my advice would be, you have to be realistic. With this assessment, we had the opportunity, because I had the phone numbers, they update the camps regularly, like on a daily basis, actually. So getting a hold of the camp managers and releasing that information for us, once we had within the camps, if there's population changes, then we could make that within 48 hours. When we went to camp, we had up to date. So if there was any population changes. I think for other assessments, the reality is, I would say, I don't want to put like percentage per se, but you have to get it as close as possible and be realistic. But I'd say the most important point, you have to do the best you can. And if you think that there is a difference, it's just something that you have to write about in your final report. The reality is with demography, the demographics, we have to just do the best you can. The reality is, in some cases, unlike a camp setting, it won't be perfect, but it's just important that you're very transparent, and then you talk about that in your report. Thank you.
Thank you, Scott. Okay, any other questions or comments for anybody? Najwa, I assume that Dr. Moazam's not with you.
No, actually, we're in different locations. I'm in Baghdad. He's in Erbil now. However, I'm not sure what he wants to share, but I do have a question concerning deployment of 3 technical people at the same time. And do you think that is really useful in terms of working with all the different partners, NGOs, the ministries, or did you face difficulty because, you are targeting more or less the same people? So how did you manage that with 3 people deployed at the same time?
It's a very good question, and it's definitely something that I think they found difficulties with. I will leave it to you guys to choose who wants to respond.
May I respond?
Go for it, Daniel.
Okay, thank you for the questions, and it's very good questions. As Andy tries to emphasize on the lesson learned, it has advantage and disadvantage. Let me start with advantage. The advantage is that having 3 deployments at the same time, it will enable us to access the same people at the same time. That's why we have done, for example, to arrange the barrier analysis and IYCF behaviors change. We didn't need to trace or hunt each peoples, because these peoples are at the same time coming for the assessments, and we used to access them easily. This is the advantage. The disadvantage is that mainly on the logistic aspect, as well as administrative aspect and security issues, because these assessments have been done simultaneously in different places. So there is challenges on the logistic aspects, as well as security issues and administrative issues. I think this is all I can say now. Thank you.
Thank you.
Thank you, Daniel. I don't know if Lovely or Scott has anything you want to add to what Daniel said.